So we talked about how these SA node fibers are capable of generating their own action potentials, and how those action potentials then propagate throughout all the atrial muscle fibers, thanks to the intercalated disc, and that causes all of the atrial muscle fibers to pretty much contract in unison. Okay, we'll get to the theoretical basis by which that happens in a little bit. All right, but let's first talk about, again, why the left and right atrial muscle fibers contract and not the left and right ventricular muscle fibers. So what exists between the left and right atrium and the left and right ventricle is what's called the cardiac skeleton. This is a very fibrous connective tissue that actually separates the left and right atrium from the left and right ventricle. So the point is this. Left and right atrial muscle fibers, cardiac muscle fibers, are not attached to left and right ventricular muscle fibers. So that action potential, action potentials, right, as they're propagating throughout the left and right atrial muscle fibers, it causes the left and right atrial muscle fibers to contract, but then that action potential is not capable of propagating into the left and right ventricle because the left and right atrial muscle fibers are not attached through intercalated discs to any of the left and right ventricular muscle fibers thanks to this cardiac skeleton. So this is actually what's going to allow for the left and right ventricle to contract before the this is what's actually going to allow for the left and right atrium to contract before the left and right ventricle contracts. All right, so obviously though, the action potential does eventually begin to propagate into the left and right ventricular muscle fibers, and the left and right ventricle contract. So how does that happen exactly? All right, so this is technically a picture of the conduction system, but we're not talking about the conduction system yet because starting off talking about the atrial conduction fibers is really a terrible mistake because they're very poorly understood, and it makes the rest of the conduction system make no sense if you try to talk about them first, in my opinion. So all I'm trying to show you here, though, is this. I mentioned this in a previous lecture, but the AV node. The atrioventricular node. The atrioventricular node, yes, it's another, what we could call pacemaker. It's not the pacemaker of the heart, but it's another collection of autorhythmic cells. Let's save that for a little bit later, though. What I really want to show you here is the AV node is really the only location where atrial muscle fibers are going to meet ventricular muscle fibers, or what will be ventricular muscle fibers. Let me try to explain. The SA node fibers generate these action potentials, and these action potentials propagate throughout all of the atrial muscle fibers, causing the atrial muscle fibers to contract. But those action potentials then cannot propagate into the ventricular muscle fibers because of this cardiac skeleton. Well, luckily, there is one place where the atrial muscle fibers do in fact meet what will be the ventricular muscle fibers, and that is at the AV node. So try to imagine this with me. The action potential right now is started off in the SA node, obviously, and is propagating throughout different right atrial muscle fibers. And what you're seeing here is these right atrial muscle fibers are actually going to be attached to these AV node fibers. These AV node fibers are also cardiac muscle fibers, okay? And they are physically attached to these, through intercalated discs, to these right atrial muscle fibers. Because I'm going to draw you an image in a second here. And what I'm going to be showing you is where one right atrial muscle fiber is meeting a AV node fiber. Again, imagine this as being the one location where the atrial muscle fibers meet what will become the ventricular muscle fibers, or when I say will become, I mean this is a direct pathway into the left and right atrium, left and right ventricle, excuse me. Right? This is a direct pathway from the AV node. Right? There are going to be cardiac fibers that ultimately lead into the left and right ventricle. The point is that I'm trying to make, if these right atrial fibers can pass the action potential to these AV node fibers, then the AV node fibers can pass the action potential to fibers that actually then lead into the left and right ventricle, and the left and right ventricle will be able to contract. All right, so again, what we really need to do is we need to look at where a right atrial fiber, right, that is receiving its action potential from another right atrial fiber that, if you followed upstream, received its action potential from one of the SA node fibers. We need to take a look at where that right atrial fiber is meeting one of these AV node fibers and look at the way the action potential is going to be passed and talk about the AV node fiber itself. So here is the right atrial, RA, right atrial contractile fiber, or it might actually be one of these conduction fibers, which we're going to talk about in a little bit. Although, again, the atrial conduction fibers, they're real wonky. All right, so let's just say here's this right atrial fiber meeting the AV node fiber, right? This is one AV node fiber. The AV node fiber is just like the SA node. It's made up of a whole bunch of cardiac fibers, okay? So the right atrial fiber and the AV node fiber are going to be attached to each other through gap junctions. How the action potential is going to be passed from the right atrial fiber to the AV node fiber should be relatively simple, right? The right atrial fiber, actually, whether it's a conduction fiber or whether it is a contractile fiber in the right atrium, makes no difference, because that's the weird thing. Contractile fibers in the right atrium and these conduction fibers that we haven't talked about yet, they propagate action potentials in the exact same way. They use a combination of voltage-gated sodium and voltage-gated calcium channels to propagate their action potentials. So the action potential is propagating down this right atrial fiber, right? Sodium is coming in first, and the interior gets up to whatever the threshold is necessary, -50, for the voltage-gated calcium channels to open up, and then calcium enters, right? That drives you to +10 or whatever it might be, right? That's what's causing this action potential to propagate down this right atrial fiber. We talked about all that in detail. All right, so the action potential is propagating down the right atrial fiber, and the right atrial fiber is attached to the AV node fiber through intercalated discs, and most importantly, these gap junctions. So what about the AV node fiber? The AV node fiber, interestingly, has a, well, first of all, the AV node fiber is a autorhythmic cell, right? Just like one of the SA node fibers is. AV node fibers are autorhythmic, just like SA node fibers are. They're capable of generating their own action potentials, and sometimes they do in people that have problems with their SA node. These AV node fibers are kind of the secondary pacemaker of the heart. Although oftentimes you'll get conduction fibers in the right atrium that play that role too, but again, talk about that later on. So AV node fibers, they're autorhythmic cells, okay, just like SA node fibers are. Okay, so they don't have resting membrane potentials. They have peak negative values, though, just like SA node fibers do under resting circumstances. And the AV node is similar to the SA node, maybe a little bit more negative, but it's not far off of the SA node fibers. It's certainly not -80 or -90 like contractile cardiac fibers are. So, just for good measure, let's say that it has a peak negative value of like -65 millivolts or something. So these AV node fibers are capable of getting to threshold on their own. they have funny channels, just like SA node fibers do. Let's just draw an SA node fiber up here. Here's an SA node fiber with a peak negative value of negative 60 millivolts. So the SA node fiber and the AV node fiber are both autorhythmic, both capable of getting to threshold completely on their own thanks to the funny channels that they have. But here's the thing, the AV node fibers, again, in a healthy person, never get to threshold really on their own, while the SA node fibers always get to threshold on their own. So why would the AV node fiber not get to threshold on its own? It's autorhythmic, but it doesn't almost ever get to threshold by itself, unless, again, you have some, it could be an acute sort of arrhythmic event, or you're actually, have some serious problem with the SA node. But generally speaking, these AV node fibers in a healthy person, throughout the course of a day, really almost never get to threshold on their own. And the general reason for this, the explanation for this, is the SA node fibers definitely get to threshold a lot faster than the AV node fibers do. Now, of course, the question is why, and I don't think anybody has the ability to answer that perfectly right now. There's all sorts of different possible explanations. Let's again just focus on how the SA node fiber gets to threshold faster than the AV node fiber does. Maybe the SA node fiber gets to threshold faster because it has a higher density of F-type channels, voltage-gated sodium channels. Maybe there's a higher density of voltage-gated sodium channels. Maybe there's a higher density of those transient-type calcium channels too, T-type channels in the SA node. If there's a higher density of these F-type channels and T-type channels, then sodium and calcium will come in at a faster rate in the SA node fiber than in the AV node fiber. Okay, and that would bring the SA node fiber to threshold faster than the AV node fiber. So thus, the SA node fiber would get to threshold much more quickly than the AV node fiber would. Additionally, maybe in the SA node fiber, there are voltage-gated potassium channels that shut faster. Again, let me be clear here. Maybe in the SA node fiber, there are voltage-gated potassium channels that shut quicker, sooner, at a more positive value, meaning these shut sooner, maybe at negative 65, they're pretty much all closed, versus in the AV node fiber, the voltage-gated potassium channels take a little bit longer to close, right? The interior needs to get to negative 65 before these voltage-gated potassium channels really shut, most of them. All right, so that's another possible explanation, and maybe all of these are simultaneously happening, okay? If this is true, and the SA node fiber has a higher density of voltage-gated sodium and calcium channels, and again, I'm talking about the F-type and the T-type channels, that would allow more sodium and calcium to come in, right, at a faster rate than the AV node fiber. Additionally, if the SA node fiber has voltage-gated potassium channels that shut sooner at more positive values than the AV node fiber, the membrane potential, right, would begin to reverse at a more positive value in the SA node fiber than in the AV node fiber. So to say that in a more simplified way, in the SA node fiber, you only need to get to negative 60 before the membrane potential begins to reverse. And in the AV node fiber, you need to get to negative 65 or maybe negative 70 before the membrane potential really begins to reverse. And then that might also be because in the SA node fiber, maybe the F-type channels and the T-type channels open up sooner than in the AV node fiber. Maybe a higher density of F-type channels begins to open up in the SA node fiber at negative 60, and it doesn't really start to open up in the AV node fiber until negative 65. That would also cause the SA node fiber to get to threshold faster than the AV node fiber. You can play this game all day long if you want to. I'll stop now because you just spin yourself in circles trying to think about this, and there's all sorts of conflicting evidence as to what's causing this. But at the end of the day, the SA node fibers, they get to threshold sooner than the AV node fibers do. And that means that the SA node fibers also generate more action potentials per minute than the AV node fibers do. But I'm getting a little bit ahead of myself. All I'm trying to show you here is that the AV node fiber is capable of getting to threshold on its own, but it almost never does. And the explanation for why the AV node fiber almost never does get to threshold on its own is because of the SA node fibers. And now let me really show you exactly what it is that I mean. So here's the SA node. Here's one SA node fiber up here. And down here is one of the AV node fibers. Okay? These are the atrial contractile fibers, and if we follow the atrial contractile fibers, we'll find that some of the atrial contractile fibers actually attach to the AV node fibers through gap junctions. Great. All right. So let's say in this instance, the SA node fiber and the AV node fiber right now are both trying to get to threshold on their own. Let's not relitigate everything that we just did, but we know that the SA node fiber is going to get to threshold a lot faster than the AV node fiber will. So the SA node fiber is going to get to threshold, and the action potential from the SA node fiber is going to begin to propagate into the contractile fibers of the atria, left and right atria, specifically the right atrium. Okay. Now, SA node fiber got to threshold. That action potential from the SA node fiber is propagating into the atrial contractile fibers. While that action potential is propagating into the atrial contractile fibers, the AV node fiber is still trying to get to threshold. The AV node fiber still hasn't gotten to threshold yet, and the action potential from the SA node fiber has already propagated through the vast majority of atrial fibers located in the heart. All right, so now the action potential is propagating into this atrial fiber right here, that attaches to this AV node fiber. The action potential is propagating through this atrial fiber, and the AV node fiber is still trying to get to threshold on its own. It still hasn't accomplished it yet. Again, maybe because it has voltage-gated potassium channels that take an extra period of time to shut. Maybe it has a lower density of F-type channels and T-type channels. Maybe those F-type channels and T-type channels don't open as soon. All those factors may be playing a role, but this AV node fiber is trying to get to threshold on its own, and it still hasn't gotten to threshold. And now the action potential is propagating through this atrial fiber that's attached to the AV node fiber through these gap junctions, and the AV node fiber still hasn't gotten to threshold on its own. So what do you think is going to happen? The sodium and the calcium that's entering into the atrial fiber as the action potential is propagating down it, that sodium and calcium is going to get pulled into the AV node fiber, right? Because inside of the atrial fiber, it's going to be like, positive 10 or so millivolts. And inside of the AV node fiber, we may still be at like negative 55 millivolts, right? So there's a very strong electrical driving force in the AV node fiber pulling those calcium and sodium ions from the atrial fiber into the AV node fiber. So then the question, of course, is, well, what actually causes the AV node fiber to get to threshold? And the answer is, what actually causes the AV node fiber to get to threshold is the action potential propagating into the AV node fiber from the atrial fiber. To say this in an easier way, I think, actually, to understand, more sophisticated but easier way to understand this, once you've studied this, is what's actually happening is the calcium and sodium ions entering into the AV node fiber from the atrial fiber. Those calcium and sodium ions from the atrial fiber are what are actually getting the AV node fiber to threshold. So the AV node fiber never actually gets to threshold on its own. It gets to threshold, the AV node fiber, but it didn't do it by itself, right? The funny channels opening up and the T-type calcium channels opening up, those didn't get the AV node fiber to threshold. What got the AV node fiber to threshold is actually the action potential from the atrial fiber, right, that attaches to the AV node fiber. The calcium and sodium ions from the atrial fiber entering into the AV node fiber. That's what it actually gets the AV node fiber to threshold. And now here comes the next part. how does the action potential propagate down the AV node fiber, and what does the AV node fiber attach to? I think I've implied that the AV node fiber attaches to other cardiac fibers that are then going to enter into and become part of the left and right ventricle. But there are some more specific details that are necessary here. It's not that simple. All right, we're still not talking about the conduction system yet, but what should be clearly evident from this picture is that the AV node fibers attach to other cardiac fibers that ultimately become, right, the left and right ventricle. Okay, so if you can pass the action potential into the AV node fibers, that action potential will then get passed into ultimately the left and right ventricular muscle fibers. That's the only thing I'm trying to point out right now. What we can say is once the AV node fibers hit threshold and they generate action potentials, that action potential or potentials from the AV node fibers are then going to spread into all of the left and right ventricular fibers, and the left and right ventricle is ultimately going to contract. But there's some, again, some very specific things that we need to take a look at before we talk about that. Here is an AV node fiber. Okay. Here is one cardiac fiber that it attaches to that's headed into or towards the left and right ventricle. Okay, if you look at this fiber that this fiber here attaches to, right, you keep following that down the line, these cardiac fibers are ultimately going to become the cardiac fibers of the left and right ventricle. All right, so point is, the AV node fiber doesn't get to threshold on its own. We're going to say threshold is around -50, something similar to the SA node fiber. Okay, that's when all the, well, let's talk about that. Okay, so sodium and calcium entered in from the atrial fiber into the AV node fiber, and that's the influx of calcium and sodium into the AV node fiber is actually what drove it to threshold. And AV node fibers, again, their action potentials are very similar to SA node fibers. So when you get the AV node fiber to threshold, what opens up are L-type calcium channels, voltage-gated calcium channels. You get this big influx of calcium through these L-type calcium channels that drives the interior up to like +10 or so, and then the calcium ions move to the next region, and that causes another collection of L-type voltage-gated calcium channels to open up. Okay, what's the point I'm making? The action potential right now is propagating down the AV node fiber in an identical way that it propagates down the SA node fiber. AV node fibers and SA node fibers propagate action potentials identically. They propagate action potentials using only calcium. Okay, I said that contractile cardiac fibers propagate action potentials using a combination of both calcium and sodium, sodium and calcium. SA node fibers and AV node fibers, both being autorhythmic cells. Now, interestingly enough, you're going to find out that this isn't always true for autorhythmic cells, but for the moment, AV node fiber and SA node fiber are both autorhythmic cells, and they both propagate their action potentials utilizing only calcium. Now, why is that so important? We have found out that this is very important, actually. And the reason that this is important is because the action potential, when only calcium is being utilized, action potentials propagate relatively slowly. When only L-type calcium channels are utilized to propagate action potentials, the action potential does not propagate fast. It's partly due to the characteristics of the L-type calcium channels. It's partly due to the fact that these SA node and AV node fibers just don't have as high of a density of these calcium channels either. Possibly, again, a lot of this is theoretical, but when you have a lower density of these voltage-gated calcium channels too, that also decreases the rate at which the calcium ions can flow in, and it decreases the rate at which the action potential can propagate. So something about the characteristics of the voltage-gated calcium channels, something about the amount of voltage-gated calcium channels, is probably all playing a role in what decreases the rate at which action potentials can be propagated when only L-type calcium channels are utilized. Nothing about this is debated. SA node fibers and AV node fibers propagate their action potentials quite slowly. The conduction velocity of the action potential is slow. Now, once the action potential gets past the AV node fibers, we'll talk about why it being slow is so important in a second, but I want to point this out. Once the action potential gets past the AV node fibers and into the fibers that the AV node fibers attach to, so this fiber over here, this is either going to be a contractile fiber or a conduction fiber within the what will be the interventricular septum. Once the action potential propagates from the AV node fibers into these either conduction or contractile fibers of what will become the, again, interventricular septum, the cardiac muscle that exists between the left and right ventricle. These fibers propagate their action potentials just like the cardiac fibers, the contractile fibers in the atrium. Okay, so when they get to threshold, a combination of voltage-gated sodium and calcium channels open up. Okay, calcium enters in through sodium and calcium. That made absolutely no sense. What I meant to say was the action potential propagates with the combination of sodium and calcium, and the point is these fibers propagate their action potentials much more quickly. When sodium, especially sodium, is utilized, action potentials propagate a lot faster. Without getting into any detail, let's talk about what I mean. What I meant by any detail is any serious detail yet. Okay, once the action potential gets past the AV node fibers into either the conduction or traditional sort of contractile fibers that will become, again, part of the interventricular septum, the action potential is going to rip through these fibers very quickly into the left and right ventricular fibers, and the left and right ventricle is all going to pretty much contract in unison. But what was the whole point of pointing out what happens at the AV node? A very important point, actually. Okay. Look at it. The action potential starts in the SA node fibers. The action potential propagates from the SA node fibers throughout all of the atrial muscle fibers. And the action potential propagates through those atrial fibers so quickly, partly because those atrial fibers use sodium and calcium to propagate their action potentials, and partly because there are these things called conduction fibers in the left and right atrium that we'll talk about later on. The action potential propagates throughout all these atrial fibers so quickly that they all pretty much contract in unison. But then what happens to the action potential as it moves from the atrial fibers into the SA node fibers? Because remember, the atrial fibers, what happens to the action potential as the action potential moves through the atrial fibers into the AV node fibers? Okay. First of all, the AV node doesn't get to threshold on its own. It's capable of doing it, but it doesn't. Why? Because the action potential moves from one of or many of the atrial fibers that attach to AV node fibers, and the action potential moving from the atrial fibers into the AV node fibers is what actually causes the AV node fibers to get to threshold. And then the AV node fibers hit threshold, and they begin generating action potentials. But what happens to the action potentials as they move through the AV node fibers? They move very slowly. Why? Because AV node fibers propagate their action potentials only utilizing calcium, L-type calcium channels. And then finally, once the action potential gets through the AV node fibers into the contractile and perhaps conduction fibers, not perhaps, there's going to be, that are going to make up the interventricular septum and ultimately lead into the majority of the left and right ventricle. As soon as you get past the AV node fibers, the action potential starts propagating very quickly again throughout the ventricular muscle fibers, and all the ventricular muscle fibers again pretty much contract in unison because the action potential moves through them so quickly. So what's the point of the action potential propagating through the AV node fibers slowly? We now know that it accounts for what is called the PR segment. What's the PR segment? The PR segment is the delay between the P wave and the QRS complex. What that really means is it's the delay that exists between when the left and right atrium contracts and when the left and right ventricles contract. We know that the left and right atrium contracts first, and then the left and right ventricle contracts. The left and right atrium contract in unison, then there's a short delay, the PR segment, and then the left and right ventricle contract in unison. Now, the explanation for why this delay needs to happen is because it allows for the left and right atrium to finish pumping the blood into the left and right ventricle before the left and right ventricle contract, which, fine, that makes sense. But what actually causes the pause? What allows for this electrical pause? Like, what allows for this pause so that the left and right ventricle, what allows for this pause so that the left and right atrium can contract and finish contracting before the left and right ventricle start contracting? The answer now appears to be quite clear. The action potentials propagate very slowly through these AV node fibers. The action potential conduction velocities are slow through the AV node fibers, and that's what creates that delay between the P wave and the QRS segment. It's what creates the delay between when the atrial muscle fibers contract and when the ventricular muscle fibers contract. To do this a different way, the action potential rips incredibly quickly throughout all of the atrial muscle fibers. Okay, it moves enormously quickly, fast, throughout all the atrial muscle fibers, allowing all the atrial muscle fibers to contract in unison. And then the action potential, to call it one action potential is often how it's discussed, right? But it's lots of action potentials simultaneously moving through all these fibers, different fibers. The action potentials, as they move through the AV node fibers, they slow down dramatically. And that's because these AV node fibers propagate their action potentials utilizing calcium L-type calcium channels. The action potentials slow down really dramatically, and that's where you see that PR segment. And then once the action potentials get past the AV node fibers, they move back into the contractile or conduction fibers that are going to become part of the interventricular septum, and the action potential again begins to rip through all of the ventricular muscle fibers, and all of the ventricular muscle fibers pretty much contract in unison, and that is where you see the QRS complex. So the AV node plays an enormously important role beyond the fact that it is kind of the secondary pacemaker of the heart. The AV node fibers are what allow for really the atrial muscle fibers to finish contracting before the ventricular muscle fibers start contracting. And this is, of course, quite important to a normally functioning heart. And there's still a lot more to say about actually how these action potentials move throughout the ventricles, and then even to go backwards and talk about how they move throughout the atria. So beyond playing that role, we can now talk about the role that everybody thinks about when they discuss the AV node, and that is that it is also one of the other pacemakers of the heart. So if for some reason the SA node stops operating, the SA node fibers fail for whatever reason the reason might be, the AV node fibers can take over, right? So the SA node fibers fail, right? They stop generating their own action potentials. The SA node fibers, thanks in a big part actually to the autonomic nervous system, which we'll talk about later on, they generate somewhere between they generate about 70 action potentials per minute. And every time the sinoatrial node fibers generate an action potential, that action potential propagates throughout all the atrial fibers first, then there's a delay, and then the action potential propagates throughout all of the ventricular fibers. And again, that repeats about 70 times per minute. So the average person has about a heart rate of approximately 70 beats per minute. Now, what about if the SA node fibers stop functioning, right? They stop working. Well, we have these AV node fibers, but what I told you about the AV node fibers is they get to threshold a lot more slowly than the SA node fibers do. And maybe just a better way of thinking about that is the AV node fibers generate a lower frequency of action potentials per minute. They generate somewhere in the range of like 40 to 50 or so, 40 to 50 action potentials per minute, right? If it takes them longer to get to threshold, they're going to generate less action potentials per minute than the SA node fibers do. So if the SA node were to completely stop operating, then the AV node would start getting to threshold on its own. Why would it get to threshold on its own? Well, it would get to threshold on its own because the SA node fibers would no longer be generating action potentials, and those action potentials would no longer be propagating through the atrial fibers. So that action potential wouldn't move from the atrial fiber into the atrial ventricular fiber before it gets to threshold and cause it to get to threshold, right? If the SA node fiber doesn't generate an action potential and the action potential doesn't move through the atrial fibers, then that action potential isn't going to move from the atrial fibers into the atrial ventricular fibers and cause them to get to threshold. The AV node fibers will actually get to threshold completely by themselves. And what will happen after the atrioventricular, the AV node fibers get to threshold on their own? Those action potentials that the AV node fibers generate, they will then move into the cardiac fibers that make up the ultimately what will become the interventricular septum, and ultimately the action potentials will propagate into all of the fibers that make up the left and right ventricle, and the left and right ventricle again will pretty much contract in unison. This can happen about, again, 40 to 50 times per minute. So if somebody's SA node fiber completely gives up, stops working, the person's heart rate would become approximately 40 to 50 beats per minute. Because what would happen? The AV node fibers would become the primary pacemakers of the heart. Now, in this case, if this were to actually happen, the heart rate would be around 40 to 50 beats per minute, and only the ventricles would be contracting, which is actually okay for a short period of time because blood actually mostly moves from the left and right atrium into the left and right ventricle through pressure gradients, and less so because of the left and right atrium actually contracting. That doesn't mean that the left and right atrium contracting isn't important, but I'm just saying for, let's say a relatively short period of time, it's okay for something like the AV node to take over. A heart rate of 40 to 50 beats per minute also is not ideal, and you don't have the left and right atrium contracting. Neither of that is good, or neither of those are good. But as long as you get to the hospital, this person gets to the hospital and gets this taken care of, it's not going to be the end of them. Now, this is not a cardiovascular physiology course, but please know that all of this is far more complicated and sophisticated when you're seeing this in real life. Like if you think about the SA node stopping and the AV node being the primary pacemaker, oftentimes you would have the sympathetic nervous system actually kick in, which would influence the AV node to actually increase its frequency of action potentials. So you could see an absence of P waves, but then actually a really high frequency of QRS complexes. I'm not, trying to teach an ECG course. I'm just trying to say, I was trying to give you a very specific example so that you can think through it in a very basic way about what would happen if the SA node were to stop, how the AV node, could play a role, what's its frequency of action potentials. But in real cardiovascular medicine, there's lots of other variables going on, and all sorts of different circumstances that could be driving these problems. So it's not just as cut and dry as I was making it. But anyways, I hope that helps with the sort of advanced but also basic understanding of what you would expect with the lack of the SA node. So what we're going to do now is talk about how it's possible for the action potential to propagate throughout all of the ventricular muscle at such a rate, at such a speed, that all of these ventricular muscle fibers more or less contract in unison. And then we'll relate it back to the left and right atrium. As I said earlier, talking about these, what are called conduction fibers in the left and right atrium first, before you talk about them in the ventricles, I think really complicates things and makes it more confusing, which is why I didn't do it. There's also just a lot less agreement on atrial conduction fibers. All right, anyways, there's a lot of ventricular muscle, especially left ventricular muscle. Okay, so for these action potentials to get through all of these ventricular muscle fibers so quickly that they all contract in unison, there has to be something else going on. And that's where these, what are called conduction fibers, play a role. Conduction fibers are depicted in different ways by different textbooks, partly because there's especially in the left and right atrium, there's not a ton of agreement on these conduction fibers, where they're located, less so about how they function, but certainly, where exactly they are. So if you look, the conduction fibers here, I mean, you can see the SA node and AV node here, but in red, these are the conduction fibers, right? So here's an image of these conduction fibers. You've seen this image a million times now. Everything in yellow, those are all conduction fibers. Okay, so what are these conduction fibers? Are they, some unique? Are they neurons located inside of the inside of the heart? Are they some other type of cell? No, they are just other. They're more cardiac muscle fibers. Conduction fibers are cardiac muscle fibers. Just like contractile cardiac muscle fibers are cardiac muscle fibers, just like AV node and SA node muscle fibers are cardiac muscle fibers. These things depicted in yellow, those are all just cardiac muscle fibers too, interspaced throughout the left and right atrium and left and right ventricle. I think it's generally fair to say that there are really three different types of cardiac muscle fibers. Not everybody's going to agree with this, but this is how I interpret it. Okay, there are true autorhythmic cells, like SA node fibers and AV node fibers. Okay, then there are contractile cardiac muscle fibers, like the contractile fibers in the left and right atrium and the left and right ventricle. And then there are conduction fibers. Conduction fibers, I would say, are the third type of cardiac muscle fiber. Now, technically, conduction fibers, as are depicted in yellow, are autorhythmic. They're capable of generating their own action potentials. But truly conduction fibers, what you're seeing there in yellow besides the SA node and AV node, the job of conduction fibers is to propagate really fast action potentials with enormously high velocities. Some people really like to lump SA node fibers and AV node fibers and then these conduction fibers all together. But I really don't think that that does justice to what's what's truly the case. All right, and I'll explain why in a second here. Yes, it's true that AV node fibers, SA node fibers, and conduction fibers are all autorhythmic, meaning they all actually have funny channels. They're all capable of getting back to threshold on their own. But that's about where it ends. Conduction fibers propagate action potentials very differently, more so like contractile fibers, than SA node or AV node fibers do. I think the easiest way to get into this is to focus on the AV node. Okay, we say that the AV node fibers just got to threshold. This is a normal situation. The AV node fibers got to threshold because the action potential propagated into them from the atrial fibers. Now the action potential is propagating through the AV node fibers and into the fibers that they're attached to through intercalated discs. The AV node fibers are going to be attached to some what are called conduction fibers, and probably also some traditional sort of contractile fibers as well. So what we can do is we can focus in on the AV node and then look at the conduction and contractile fibers that the AV node is associated with or attached to. So what we're going to focus on is these AV node fibers meeting particularly these conduction fibers. Again, AV node fibers are cardiac muscle fibers. Conduction fibers are cardiac muscle fibers. Okay? And the conduction fibers that the AV node fibers are meeting up with are part of what's called the bundle of His. And we'll talk about the bundle of His in just a little bit. So here is an AV node fiber. And attached to this AV node fiber are what are called these conduction fibers. This is a conduction fiber of what's called the bundle of His. Okay, most of the, if not all, but certainly most of the AV node fibers are attached to the conduction fibers that are going to form the bundle of His. And they're attached, of course, through gap junctions, which are part of intercalated discs. All right, so what's happening? The action potential is propagating down this AV node fiber quite slowly, because it's propagating its action potential strictly with calcium through these L-type calcium channels. And then next to it is this, or attached to this AV node fiber is this conduction fiber, this fiber that's part of this bundle of His. All right, so conduction fibers are quite interesting. Okay, they don't have resting membrane potentials because all conduction fibers technically are autorhythmic. They are autorhythmic just like AV node fibers are, and just like SA node fibers are. But the conduction fibers really almost never, throughout a lifetime, get to threshold on their own. First of all, their peak negative value is like between negative 80 and negative 90. Oops, what's going on there? As I was saying, between negative 80 and negative 90 or so, okay, they have a pretty peak negative value, a pretty negative peak negative value. That is a little bit of a tongue twister, but they don't have a resting membrane potential. They technically have funny channels, but again, their peak negative value is very negative, and it takes them a very, very long time to get to threshold. Exactly why these fibers take so long to get to threshold, it could be due to a variety of reasons related to like why it takes AV node fibers longer to get to threshold than SA node fibers. But that's obviously amplified in the conduction fibers, one, because they have a more negative value. It could be related to the funny channels themselves and the other types of, potassium channels. And some of these things about conduction fibers we actually understand the least about. But without getting into all of the hypotheticals, what do we know for sure about conduction fibers? They have a very, very negative peak negative value. Their peak negativity is closer to the resting membrane potential of the regular contractile fibers of the heart. And they take a long time to get to threshold. All of these factors mean, yes, conduction fibers are autorhythmic, but they generate very, very infrequent action potentials. Many of the conduction fibers in the ventricles, for example, we believe on their own would generate about 20 action potentials per minute. That's really not the important part of this, though. Okay, for the clarity, that's technically true for some reasons that we don't understand. But what's really the point of the conduction fibers? All right, let's get there. So the action potential is propagating down the AV node fibers. It's utilizing calcium. And then the calcium, through an electrical driving force, is going to begin to spill into the conduction fibers. And this is where things get really confusing, actually, part of which is going to be confusing enough that I don't have entire explanations for all of this, because nobody does. But conduction fibers, they probably get to threshold about 15 millivolts above their peak level of negativity, maybe a little bit higher than that, maybe 20 millivolts. Regardless, let's say that they get to threshold around negative 75 to negative 60 millivolts, 20 millivolts more positive, or negative 75, whatever. When they get to threshold, what actually opens up are voltage-gated sodium channels. So these are autorhythmic cells that have voltage-gated sodium channels. That's a really important point to make here. This conduction fiber doesn't get to threshold on its own. It gets to threshold because the calcium ions, the action potential, is spilling over from the AV node fibers into these conduction fibers. And that influx of calcium ion gets the conduction fibers to threshold. And when they get to threshold, voltage-gated sodium channels open up. Sodium rushes in, and then that causes voltage-gated calcium channels to open up. What's the point I'm trying to make here? Once we get to, let's say that we get to negative 50 or something, then approximately the voltage-gated calcium channels open up, and calcium spills in. These are the L-type calcium channels. Okay. It looks like those T-type channels are pretty much limited to the AV node fibers and the SA node fibers. However, that could change with time. We don't see a lot of those in contractile fibers and in conduction fibers. Big point here. Conduction fibers and regular contractile fibers of the heart propagate their action potentials very similarly. They propagate their action potentials utilizing a combination of both sodium and calcium. So the only fibers that we know of that really only propagate their action potentials with calcium in the heart are the AV node fibers and the SA node fibers. Regular contractile fibers and these conduction fibers propagate their action potentials utilizing both sodium and calcium. So what's happening now? The action potential is going to start propagating down these conduction fibers utilizing a combination of both sodium and calcium. And what's this conduction fiber going to be attached to? It's going to be attached to another conduction fiber through intercalated discs, specifically gap junctions here, and sodium and calcium are going to spill from this conduction fiber into the next conduction fiber, make it hit threshold, right? And then an action potential is going to propagate down this conduction fiber utilizing both calcium and sodium. So I think I can go ahead and tell you this. The reason that these conduction fibers want to use voltage-gated sodium channels more specifically is because, again, when we utilize sodium, action potentials can propagate much faster than when calcium is used alone. Probably something related to the permeability of the voltage-gated sodium channels to sodium, allowing for a greater influx, and something related to the density, the number of voltage-gated sodium channels that can exist in the membrane. Basically, the greater the influx of a positive ion that's led into each region, the faster that potential can travel. And that's actually very easy to explain. If you only let's say, a smaller quantity, let's say the voltage-gated calcium channels, something about their permeability, something about the quantity of them, it just doesn't allow a ton of calcium ions to be able to come into each one of these regions. It allows enough to come in, but it doesn't allow a lot of calcium like the voltage-gated sodium channels do. So when you open up these voltage-gated calcium channels, just simply not as much calcium can come in. That causes the interior of the that causes basically that region of the cell, the cardiac fiber, to depolarize, but it doesn't depolarize all that quickly. So the point is, it takes a while to get this next region up to threshold. It takes longer. It doesn't take a while. This is measured in milliseconds. But it takes a longer period of time to get enough calcium ions in here to get the next region to threshold to open up the next batch of voltage-gated calcium channels. And the point is, when you utilize voltage-gated sodium channels, something about the channels, maybe the permeability to sodium, coupled with, the density, the number of voltage-gated sodium channels that are there, they allow a higher quantity of sodium to come in. That causes the membrane potential to rise faster and gets the next region to threshold faster, and thus the action potential propagates faster when you use voltage-gated sodium channels. And thus, these conduction fibers can propagate action potentials very quickly. In fact, these conduction fibers can propagate action potentials way faster than any other cell in the heart. The regular contractile fibers of the heart cannot propagate action potentials nearly as fast as these conduction fibers can. It's not even close. Why? Well, another thing that's somewhat of a mystery, but what you'll oftentimes hear is, well, the conduction fibers, first of all, they don't have as much actin and myosin inside, right? And when you reduce the number of organelles, so basically the number or density of myofibrils inside of these conduction fibers, that allows for the action potential to propagate faster. Maybe these conduction fibers have an even higher quantity or a slightly different type of voltage-gated sodium channel. Who knows exactly, but we are confident that the conduction fibers propagate without question the action potentials at the highest velocity. These action potentials can be propagated ridiculously fast through these conduction fibers. Why that is? Probably something related to the fact that the conduction fibers don't have as much actin and myosin, and something related to the type or number of voltage-gated sodium channels that they have. Now, the point of all of this is to say conduction fibers propagate action potentials at very high velocities. They propagate action potentials incredibly quickly. Okay, well, if you look, the AV node fibers are pretty much strictly attached to conduction fibers. Okay, the AV node fibers are attached to other cardiac muscle fibers, but the fibers that the AV node are attached to are conduction fibers, and they're the conduction fibers of what we've called, or not we, but what's called the bundle of His. What does that mean? Everything that you see here throughout the bundle of His, those are all conduction fibers. Those are cardiac muscle fibers, but they're conduction fibers. The point is that these propagate action potentials ridiculously quickly. So once you get past the AV node into these conduction fibers that make up the bundle of His, what's going to start to happen is the action potential is just going to start to tear through these fibers. And what do you notice? The bundle of His, it branches into what are called the bundle branches. The bundle branches are just more conduction fibers, okay? It's not like there's some change that we really see between the bundle of His and the bundle branches. Things like anatomically, the bundle branches, of course, there's a bifurcation there in the fibers. Some of them begin to travel down the left side of the interventricular septum. Some of them begin to travel down the right side of the interventricular. The diameter might change a little bit. The frequency of action potentials that they generate could change a little bit. But I'm just saying structurally, these what are called the bundle branches are structurally really identical to the bundle of His. They're conduction fibers that are designed to propagate incredibly fast action potentials. And then what do the bundle branches become? What are called the Purkinje fibers. And the Purkinje fibers go up the left and right ventricle. So, point I want to make. The bundle of His, the bundle branches, and the Purkinje fibers are all continuous with each other. They're all attached to one another. I mean, you can clearly actually see that depicted in the image here, right? The bundle of His, the bundle branches, and the Purkinje fibers are all continuous. They're all attached. They're not literally all attached to one another, but they're all continuous with each other. It's not like the bundle of His stops and then the bundle branch is, there's like a gap and then the bundle branches start. Basically, once the bundle of His enters into the interventricular septum, the bundle of His bifurcates, right? And then once it bifurcates, we call it the bundle branches. And then once the bundle branches start traveling up the left and right ventricle, we call them the Purkinje fibers. But these are all conduction fibers that are all continuous with one another. So first of all, what's the, kind of the point of saying this? The action potential is going to spread through these conduction fibers at an incredibly rapid pace, right? The action potential is going to spread through the bundle of His into the bundle branches, which are located within the interventricular septum, and then through the Purkinje fibers, which is located in the meat of the left and right ventricle, at an incredibly rapid pace. And then the question becomes, well, what is the point of this? What's the point of the action potential propagating through these conduction fibers so quickly? And you have to realize these conduction fibers are not designed to contract, really. There is actin and myosin within them. They are cardiac muscle fibers, so they do have the ability to contract a little bit. But what you'll notice about these conduction fibers is, too, if you look at their action potential, they have less of that plateau again compared to regular contractile fibers. They don't have as much of a plateau, which immediately indicates these fibers are really not designed to contract much. They don't have that continual influx of calcium as much as the regular contractile fibers do, because they don't need it to contract. Their purpose is to propagate rapid action potentials. To understand why this is the case, we have to take a look at a conduction fiber. Here's a conduction fiber, and we know that cardiac muscle fibers branch. So here's this conduction fiber, right? It's branching here, it's branching here, and it's branching here. Okay? And here it attaches with a fiber. Here it attaches with a fiber. And here it attaches with a fiber, right through intercalated discs. So there's a gap junction here, there's a gap junction here, and there's a gap junction here, right? Attaching this conduction fiber to these other three fibers. Okay, so here's what I'm going to show you. Obviously, you know, this is an oversimplification, but we'll say that this fiber here is another conduction fiber, and this would be like this would begin to happen once the bundle of His enters into the interventricular septum, because that's where really you find a lot of cardiac muscle. Okay, so you would see that the conduction fibers, right? Some of the branches of these conduction fibers would attach to other conduction fibers. And some of the branches of these conduction fibers would attach to other contractile fibers. So the point is, these conduction fibers, some of the conduction fibers, they attach, you know, some of the branches of the conduction fibers attach to other conduction fibers, and some of the branches of the conduction fibers attach to contractile fibers that are actually located, in this case, in the interventricular septum, or if this is the, you know, Purkinje fibers, within the left or right ventricle. Okay, so as the action potential propagates through these conduction fibers, where's it going to spread into? The action potential is going to spread into, well, other conduction fibers. And some of the action potentials, because again, cardiac fibers branch, some of them are going to spread into actually contractile fibers. So the action potential is going to propagate from the conduction fiber into other conduction fibers and also into other contractile fibers of the interventricular septum, of the apex, of the left and right ventricle. So what benefit does this serve? Well, take a look here. It's never depicted perfectly in textbooks, which I think can make it quite confusing. But what's happening as the action potential propagates through these conduction fibers, the action potential is not just traveling through the conduction fibers, it's being passed into the actual contractile fibers too of the interventricular septum, of the apex, of the left and right ventricle, right? These action potentials are traveling through the conduction fibers and being passed to other conduction fibers, but also being passed to the regular contractile fibers of the interventricular septum, of the apex, and of the left and right ventricle. So here's the purpose of the conduction fibers, which I talk about in other courses, but just not in this sort of detail. The purpose of the conduction fibers is to propagate rapid action potentials so that those action potentials can actually be passed to all of the contractile cardiac fibers of the left and right ventricle and interventricular septum pretty much simultaneously, so that the entire left and right ventricle and apex and interventricular septum, all of the contractile fibers that make up those portions of the heart, all those fibers can more or less contract in unison, which is incredibly important for the normal functionality of the heart. You need, obviously, right? You need more or less all of the fibers, the cardiac fibers, located in the interventricular septum, in the apex, left and right ventricle, to pretty much contract at the exact same time. And what allows for that to happen without question, especially in the lower chambers of the heart, are these conduction fibers. If you were to remove the conduction fibers, so the bundle branches especially and the Purkinje fibers, if you were to remove them, take them out of the heart, you would see different portions of the heart contract at different times. The interventricular septum would contract first. You know, it's not like it would literally contract and then the apex would start contracting, but the interventricular septum would start contracting way before the apex would start contracting, and the apex would start contracting way before the cardiac fibers in the left and right ventricle would start contracting. And that would be an absolute catastrophe for the heart. The conduction fibers are what ensure that all of the fibers that are the cardiac fibers that are a part of the lower chambers of the heart can more or less contract in unison. And they do that by propagating the action potential through them so quickly, right? These conduction fibers propagate action potentials at such rapid paces that their action potential propagates through all these conduction fibers so fast that it spreads to all of the contractile fibers within the left and right ventricle, interventricular septum, and apex so fast that they all contract in unison. So the conduction fibers are phenomenally important to the heart. Now, do these conduction fibers exist in the left and right atrial muscle fibers? So as is being depicted in this image, these are conduction fibers. Okay. And the answer to that is there's a lot of debate around conduction fibers within the left and right atrial fibers. Some people still don't really believe that they exist. There's not a lot of cardiac fibers within the left and right atrium to begin with. That means there's not actually a lot of fibers that need to have action potentials passed to them. So the necessity of having conduction fibers certainly isn't as relevant in the left and right atrium as it is in the left and right ventricle, which has way, way, way more fibers within it than the left and right atrium does. The answer to this is there's probably conduction fibers within the left and right atrium, just like there is throughout the lower chambers of the heart. But beyond that, not a lot is known about these fibers, if in fact they do exist, which they probably do to some degree. What's their peak negative potential? Are they autorhythmic in the first place? Or are they just like the other atrial fibers with just an increased ability to propagate action potentials? There's a lot of unknown questions related to these atrial conduction fibers, if they are in fact there. For the sake of being as up to date as possible, it looks like there again are conduction fibers throughout the left and right atrial muscle, but a lot of their functionality, mechanics related to action potentials, resting membrane potentials, a lot of this stuff is not clear. So let's just say that these conduction fibers do exist within the left and right atrial muscle, and they of course would help propagate the action potential at very high velocity so that it spreads into all of the left and right atrial fibers fast enough so that they all can contract pretty much in unison. They would propagate their action potentials utilizing a combination of both sodium and calcium, of course, just like the conduction fibers that make up the bundle of His, bundle branches, and Purkinje fibers, but many factors such as like peak negative value or exactly how their autorhythmic behavior works, if it does at all, a lot of that stuff is it's just not clear. So let's go ahead and finish this off. I'm going to go through what you would hear, in your freshman anatomy class. And my hope is after this, now, if you didn't already, if you did, that's great. If you didn't already, now you actually understand what's being told to you. What do you hear in freshman anatomy? The action potential starts in the SA node, and then the action potential moves throughout the atrium, or the atria, excuse me. And then the action potential goes to the AV node. And then from the AV node, the action potential moves to the bundle of His, into the bundle branches, and then up into the Purkinje fibers. You memorize that, and that's pretty much the end of it. Maybe you're told that these fibers can propagate action potentials quickly, and then you remember their different autorhythmic rates, meaning action potential frequencies, and that's pretty much where it stops. Okay, but let's actually think through what's really happening. First of all, the sinoatrial node fibers, the sinoatrial node is made up of a collection of cardiac muscle fibers. They generate their own action potentials for all of the reasons that we just discussed, the funny channels, the transient type channels, the L-type calcium channels, and the SA node fibers propagate their action potential only using L-type channels, voltage-gated calcium channels. All right, then the action potential begins to propagate from the SA node fibers into the atrial contractile fibers. There are probably conduction fibers that also exist and are attached to the SA node fibers. And those conduction fibers, as you can see is depicted in this image, they travel throughout the left and right atrial muscle and help ensure that the action potentials propagate throughout all of the left and right atrial fibers so that they can all pretty much contract in unison. All right, but after the SA node fibers generate action potentials, what do we know? Those action potentials propagate throughout all the left and right atrial fibers, probably with the help of these conduction fibers to ensure it happens fast enough. And then the left and right atrium contract because the fibers of the left and right atrium contract. Then the atrial fibers, which are attached to the AV node fibers, right, pass the action potentials into the AV node fibers before the AV node fibers ever hit threshold on their own. Then the AV node fibers hit threshold and they start generating action potentials, but the action potential propagates through the AV node fibers very slowly because the AV node fibers propagate their action potentials utilizing only L-type calcium channels, which means the action potential propagates slowly. That's where we see this PR segment, the delay between the contraction of the left and right atrium and the left and right ventricle. All right, so the action potential propagates through the AV node fibers quite slowly, but then finally it propagates into the conduction fibers that make up the bundle of His. And all these bundle of His fibers are attached to one another. Right? There's going to be thousands of them. And the action potential really starts ripping through these bundle of His fibers. These are conduction fibers that are designed to propagate action potentials at rapid velocities, very high velocities. Once the bundle of His fibers enter into the interventricular septum, they bifurcate and form the bundle branches. As the action potential is traveling down, the bundle branches, conduction fibers, the bundle branches are conduction fibers. So once the action potential is traveling through the bundle branches, these conduction fibers, it's also, being spread into the regular contractile fibers that make up the interventricular septum. Okay, so the bundle branch fibers then begin to move up, each one of them begins to move up the left and right ventricle. As the action potential is moving through these Purkinje fibers, it's also being passed, right? Because conduction fibers are just regular cardiac fibers and they branch, right? So they pass action potentials to more than just one cardiac fiber. So as the action potential is moving through these Purkinje fibers, it's also being passed into the ventricular, the ventricular contractile fibers of the left and right ventricle, right? So as the action potential is moving through the bundle of His conduction fibers and the Purkinje conduction fibers, it's also being spread into the contractile fibers of the interventricular septum and the left and right ventricle. What's the purpose of these conduction fibers? So that the action potential rips throughout the interventricular septum, apex, and left and right ventricle so quickly that it spreads to all of the contractile fibers of these regions of the heart so quickly that they all can contract in unison. So the point is, once the action potential moves beyond the AV node and into the bundle of His conduction fibers, very quickly after that, you're going to see the entire left and right ventricle contract, which will be the QRS complex on the ECG. And that is the process of contraction throughout the entire heart. Now, part of the problem with this is that you'll hear that the conduction system is made up of the SA node, the AV node, the bundle of His, the bundle branches, and the Purkinje fibers. I don't think that that's helpful to say because the word conduction is in there, the conduction system. I try to never use that term when I'm talking about this with people because the SA node fibers and the AV node fibers, while of course they're associated with the conduction fibers, to say that they're part of the conduction system, I think is very confusing. The SA node and AV node fibers are the true autorhythmic cells of the heart. These conduction fibers, on the other hand, serve the purpose of propagating rapid action potentials. Their job is not to be autorhythmic, although they are. That's almost never, throughout a lifetime, the purpose that they'll serve. These conduction fibers really never generate their own action potentials. You see that in, again, unhealthy people or people with certain diseases, but in the average person, the conduction fibers do not play a role ever with regard to being autorhythmic. So this is the only time in the entire class where I'm going to say I don't have time to cover this next part in its entirety, but I'm still going to talk about it a little bit. Okay, so you might ask to finish this, what about the T wave? The T wave is clearly the repolarization of the fibers of the lower chamber. So the fibers that make up the interventricular septum, apex, and left and right ventricle. The T wave is when these fibers are repolarizing, getting back to either their resting membrane potentials in the case of the contractile fibers, or their peak negative value in the case of the conduction fibers. And again, the T wave is specific to the lower chambers. And they need to repolarize, of course, so that another action potential can be passed to them, and they can either propagate the action potential really quickly in the case of the conduction fibers, or they can contract again in the case of the contractile fibers. But the thing about the T wave that's fascinating and very confusing unless you really study this is the fact that it's an upward deflection. Okay, so when you do in ECG, you have a negative electrode on what's called the right arm, and you have a positive electrode on what's called the left leg. And oftentimes you hear this nonsense of like, if the action potential travels towards the positive electrode, then you get an upward deflection. That is so ridiculously oversimplified. While technically that's sort of true, this is another thing that's often done in physiology. It's just, I refuse to tell people that because it's so oversimplified that if you ever really discuss this stuff, it's awful. What's really happening, again, this is something I just don't have the time to get into, is the positive electrode and the negative electrode, they're actually measuring the voltage of the extracellular fluid and how it's changing. So as the action potential, is sort of like moving away from the negative electrode, don't think about it that way, but that's how it's been discussed. So okay, as the action potential is spreading, let's say this more accurately, throughout the left and right atrium, throughout the conduction fibers and the contractile fibers of the left and right atrium, what's happening? The inside of the fibers are becoming positive as the action potential is propagating, and the outside of the fibers is becoming negative. Okay. Outside of the fibers, it's negative, 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 negative as the action potential propagates. Right, because sodium and calcium is entering in to both the conduction fibers and the contractile fibers, making the inside positive, and then the exterior is becoming negative. Okay. Down in the lower chamber, all of the fibers are still negative on the inside, and the outside is positive, 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 positive. Okay, so in the extracellular fluid of all of the conduction fibers and the contractile fibers within the interventricular septum, left and right ventricle, the extracellular fluid is positive everywhere. But right now, in the extracellular fluid within the left and right ventricle, left and right atrium, all of the fibers within the left and right atrium, on the exterior, it's negative right now. All right, again, I just don't have the time to do this, but what's happening right now is towards the positive electrode, the extracellular fluid, if we look at this as, we look at this as a cumulative, okay? Throughout the heart, there's a much greater amount of positively charged extracellular fluid than there is negatively charged extracellular fluid. Throughout all of the interventricular septum, left and right ventricle, the extracellular fluid is all positive outside of the fibers, and only in the left and right atrium, as it's propagating through these atrial fibers, is the fluid in the extracellular fluid negative. So since there are since the extracellular fluid is much more positive towards the positive electrode and negative towards the negative electrode, that's where you actually see upward deflections. This is actually true for EMGs too, although EMGs are often rectified, so you don't really see true downward deflections. But regardless of that fact, if you look at a raw EMG, you'll see upward and downward deflections. The fact that the extracellular fluid is more positive towards the positive electrode and more negative towards the negative electrode is what actually gives you the upward deflection, and thus what's called the P wave. And then as soon as you start getting into the QRS complex, it becomes ridiculously complicated. The movement of the action potentials through the interventricular septum, apex, and left and right ventricle is totally it's purposely organized in the way that it is, but logically it's so disorganized. And it's what creates that bizarre QRS complex. Part of the reason that the upward deflection is so much more significant in the QRS complex than the P with the big reason is just because there are so many more fibers in the left and right ventricle than the left and right atrium. there's just purely a lot more electricity. Now, throughout the first half of the action potential, propagating throughout the basically the lower chambers, right? As the action potential is propagating, especially through the bundle branches, and that action potential is being propagated and passed into the contractile fibers that make up the interventricular septum. Yes, it's becoming negative, 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 negative all around the interventricular septum, but it's still positive, positive, positive everywhere else. Okay, it's positive throughout all of the left and right ventricle. Okay, so if you actually look towards the positive electrode, there's still, the extracellular fluid is still, substantially more positive than negative. So if we compare the positive electrode to the negative electrode, there's many more positively charged ions in the extracellular fluid than there are negative charges in the extracellular fluid. So you get another like massive upward deflection. And please know this is all a little bit more complicated than what I'm doing, because again, I just don't have the time. But then at some point in the QRS complex, you actually see like a downward deflection. And you'll see a downward deflection as the action potential has actually at one point propagated throughout all of the ventricles, right? And at that point, it's negative, 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 kind of everywhere. And back up in the atria, right? It's reversed, right? It's like positive, 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 positive. Again, since all of these atrial fibers have repolarized, they're back to being negative on the inside and positive on the outside. And if you look down towards the ventricles, right, it's negative everywhere. Because all of these ventricular fibers just generated action potentials. It's positive on the inside, it's negative on the outside. So now you have a reversal. Towards the positive electrode, it's all negative in the extracellular fluid, and towards the negative electrode, it's all positive in the extracellular fluid, and then you actually end up with a downward deflection. All right, but here's the confusing part. And again, please note, everything that I just went through there is not a perfect explanation of this. Honestly, I think that you'd want to spend 4 or 5 lectures really going through all of this to make complete sense of what's happening in each one of these phases. And we're approaching the end of the class, and I still have a lot I want to talk about, so it's just not realistic. All right, so obviously when you repolarize, like what would you expect? You would expect, right, like the interventricular septum to start repolarizing, meaning that the fibers of the interventricular septum, the bundle of branches, and the actual contractile fibers in the interventricular septum become negative on the inside, and then the exterior would become positive again. And then throughout the ventricles, it would be still all negative. So you would still have more positive, ions, positive charges in the extracellular fluid towards the negative electrode than the positive electrode, and you would expect the T wave to be a downward deflection. That's the obvious thing intuitively that everybody would expect. But the really fascinating thing is that the lower chambers repolarize in reverse. Repolarization, and again, we're now getting into things, again, that we just don't fully understand about the heart. I mean, you can get into all these theoretical stuff about when the voltage-gated potassium channels would shut in one fiber versus another, which has to account for some of this, but exactly what's going on and exactly the organization and the different types of potassium channels that vary between fibers, it's just not all that clear. But what we know, definitely, without question, is that the ventricular fibers start repolarizing first, right, before the fibers of the interventricular septum do. So what do you begin to see? You begin to see positive, 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 positive over all of the ventricular fibers, right? And the interventricular fibers stay negative, 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 because they haven't repolarized yet. The extracellular fluid outside of the fibers of the interventricular septum is all negative because it's still positive on the inside. And the fibers that make up the left and right ventricle and apex, they're all repolarizing. The interior is becoming negative again, and the exterior is becoming positive again. So again, if you look towards this positive electrode on the left leg, you'll begin what you're actually beginning to see is that there's more positively charged ions in the extracellular fluid towards the positive electrode, and there's more negatively charged ions in the extracellular fluid towards the negative electrode, and thus that is why you see the upward deflection that is the T wave. I didn't give you the kind of explanation about all this that I really would have liked to, because even in an advanced class like this, we still get limited. I could probably teach 5 more renditions of this course and still not get through everything that I'd like to. But if anything you can take out of this, please, the next time you hear if the action potential heads towards the positive electrode, it causes an upward deflection, disregard it, because it is, again, way, way more complicated than that. I get trying to simplify things, especially for people that are beginners, but this is just one of those areas, from my experience, that creates way more problems than it creates anything that's helpful. And I also hope that looking at this and seeing that the lower chambers actually repolarize in reverse tells you actually how little we still understand about sort of the action potential mechanics of all of these different cells. We know it happens, but how and why it happens, it's like we have ideas, but again, this implies that legitimately the contractile fibers within the ventricles are different than the contractile fibers in terms of their action potentials than the fibers in the interventricular septum. Our understanding of the heart will continue to evolve with time. But I can promise you, in another 50 years, in another 100 years, we're still not going to understand all of the differences between all of these different fibers that actually exist within the heart. It's an incredible and phenomenally complex machine.